All right, let's go ahead and get started. I want to welcome everyone to today's event. It's entitled Real Talk, Men's Brain Health, Sleep, and Caring for Others. My name is Roland Thorpe. I am the Master of Ceremonies today, as well as I am a faculty member at the Johns Hopkins Bloomberg School of Public Health, the director, one of the directors of the Johns Hopkins Alzheimer's Disease Resource Center on Minority Aging Research. I'm very delighted to be here today. I have an outstanding event. Today's event is the ninth in a series of educational programs that are a result of collaborations between multiple groups. That is Morgan State University and Johns Hopkins. Together, these programs are designed to increase community awareness on topics related to aging, brain health, Alzheimer's disease, and related dementias, to help highlight the importance of diverse participation in research, and to allow a platform for open discussion and engagement around these topics. Mhm. Okay. All right. So today's presentation today's event will take place in two parts. First, I'll give you a very brief overview of the importance of men taking charge of their brain health. And then after that, we're going to have two outstanding presentations, one by Dr. Anthony Briggs and then one by Mr. Christopher Barnes. These presentations would then be followed by a panel discussion, which will include an opportunity for the audience members to ask questions. But before we begin, I'd like to provide a few quick reminders to our audience. Throughout the session, please put any questions you may have in the chat box or save them until the panel discussion. Please also keep your microphone muted during the presentations and the panel discussion unless otherwise invited to unmute. Last, this seminar is being recorded. We will post the recording to YouTube and share the link with all registrants in case you'd like to revisit the content to share it with others. Before I get started, the presentations, I'd like to acknowledge our event organizers. This event is presented by the Morgan State RCMI, as well as recently established Center for Brain Health Research. It's also co-sponsored by Morgan Cares, the community engagement core of the Center for Urban Health Disparities Research and Innovation at Morgan State, the Johns Hopkins Alzheimer's Disease Research Center, and the Johns Hopkins Alzheimer's Disease Resource Center for Minority Aging Research. Now I'd like to give you a brief overview of men's brain health. So as we know, it's already well known that there are stark health disparities as it relates to Alzheimer's disease and related dementias, such that African Americans are 2 times more likely and Hispanics are 1.5 times more likely than their white counterparts to develop have higher rates of Alzheimer's disease and related dementias. But as it relates to when we think about think about men and men's brain health, we know that men is a understudied men, particularly men of color, are understudied population as it relates to brain health. And men face a distinct and often unrecognized set of risk factors that contribute to poor brain health outcomes. For example, cardiovascular conditions such as hypertension and heart disease, which are highly prevalent among men, are closely linked to cognitive decline and other neurodegenerative disease. Also, lifestyle behaviors, including higher rates of smoking, excessive alcohol use, and lower engagement in health promoting activities, they also further compound these risks. And men are also less likely to utilize preventive health services or seek early intervention of cognitive mental health concerns, often due to the stigma that has always been stigma and associated around norms of masculinity. Also, occupational exposures to toxin substances, which are common in male-dominated industries, they present additional risks. And then finally, we have these mental health challenges, sleep disorders, and such as obstructive sleep apnea, that are also associated with risk. And then finally, when we think about disparities, there are disparities even among men as it relates to education and socioeconomic factors that then further compound these risks and make it very difficult for us to advance our understanding and provide evidence base so that we can promote more health strategies and policy level solutions for a population that's often underrepresented in underrepresented in brain health. Now, I want to briefly touch through some of the things that I think that are important for us when we're thinking about approaching to addressing disparities in men's brain health, particularly as it relates to men of color. We need to have more men of color in cognitive and studies that focus on cognition, cognitive trial, brain health trials, because if we don't have that, then how do we know that whatever the outcome of the trial is, how do we know that it's generalizable to this group? There's work to be done in encouraging and getting a larger, more diverse sample of individual and trials that help us learn more about brain health. And now also there's importance of thinking about when we do conducting research, thinking about focusing within groups and focusing on groups. For example, we need to move beyond just merely thinking about comparing blacks to whites and think about the such heterogeneity that exists within groups that afford us the opportunity to understand the pathways by which that particular population of the priority population of interest then impacts cognitive health outcomes and improve those. And thereby improving those, we will then should be able to close the observed racial gaps. And as it relates from a methodological standpoint, I think we need to employ more qualitative and mixed methods approach because we need to move beyond just surveying. I think it's also understanding a person's lived experience and not only understanding their lived experience, but understanding their lived experience across the life course, that how things and lived experiences impact later life outcomes or how they impact the ability to do some of the lifestyle modifications that could impede the progress or delay the onset of brain health outcomes. And then finally, we're thinking about understanding the life course perspective. Not taking a life course perspective, I think when we think about understanding different racial ethnic groups or identity groups, I think is not understanding, I think is a major missed opportunity because we know, particularly in the United States, in the American context, there are different social and structural systems that have been put in place that does constrain individual choices for different groups. And we want to be able to account for those and be able to think about how to deal with those and negotiate those as we all move forward to try to think about improving men's brain health. And finally, I just want to conclude really briefly and say that I think we can achieve um, brain health equity, particularly as it relates for all. And I think one of the things that we needs to do is we need to have an interdisciplinary team to do that. And I also think we need better methodological approaches to move beyond just what has typically been done, which has been for us to think about surveying people, but I think employing mixed methods and qualitative work, it would be a huge step forward for us to be able to get these lived experiences and voices of those from the community being heard. And then finally, the life course perspective, I think it affords us the opportunity to think about how things that happen early in the life course impact later life choices, and as a result, leading to different outcomes as it relates to men's brain health. So I think I just wanted to give a brief overview of that because I wanted us to make sure we had enough time to hear from our two esteemed speakers. In the next, I'd like to first introduce our first speaker. And our first presentation will be from Dr. Anthony Briggs. Dr. Anthony Briggs is a research assistant professor in the Department of Neurology at the New York University Grossman School of Medicine. His research focuses on examining aging, men's health, sleep health, cognitive mental health, biomarkers, health policy, particularly within African, Caribbean, and the Black diaspora. He focuses on how social factors affect health in communities with the emphasis on global public health and health education. He's also on the primary council on lifestyle and cardiometabolic health for the American Heart Association. Today, Dr. Briggs will be discussing sleep, cognitive health, and brain aging. Dr. Briggs.
Great. Thank you very much for that introduction and for that opening statement. Let's see if I can share. Uh,
You got it, Dr. Briggs?
Okay. So
You should be able to go at the bottom, and then at the bottom, you should be able to see a green, excuse me, you should be able to see a box that has an arrow in it that says share.
yeah, I think that's it right there.
I think it's coming up. Yep. Yep. You just need now to go to presentation mode. Yep. I see you.
Okay. All right. Let's begin. Okay, so thank you for inviting me to speak today. And so today I'll be speaking on cognitive sleep among Black males. We'll just get right into it because I think the introduction was pretty sufficient. Um, and so, yeah, the title of my presentation is Cognitive Sleep Among Black Males. The presentation is rooted in my core statement, which is really addressing cognitive sleep, uh, health, and social determinants of health among Black males while promoting healthy coping strategies for Black males. So today's learning strategies or objectives would be to address dementia, to address physiological, neuropsychological health disparities amongst Black males, potential mechanisms of disparities, and brain health equitable community approaches in practice and policy. So dementia is a syndrome. Dementia is generally a term for loss of memory, language, problem solving, other thinking abilities that interfere with the daily and occupational activities. There are multiple causes of dementia. And as you can see based off the image, there's the frontal temporal lobe dementia, and it's a group of brain disorders caused by progressive damage to the frontal and temporal lobes leading to changes in behavior, personality, language, and cognitive function. And then there's vascular dementia. It's a reduced blood flow to the brain, leading to damage in the brain tissue, for example, a stroke, and resulting in problems with memory, thinking, and reasoning. Then there's Lewy body dementia. And it's a progressive brain disorder characterized by the accumulation of abnormal protein deposits called Lewy bodies in the brain, interfering with the brain functioning, leading to cognitive, motor, and behavioral symptoms. However, Alzheimer's disease is the most common cause of dementia. There are two toxic proteins that contribute to Alzheimer's disease. As we look at the Alzheimer's disease brain, amyloid plaques is a protein that builds and clumps together to form plaques outside the cells in the brain, while neurofibrillary tangles, or what is also known as NFTs, are abnormal accumulations of protein called tau that collect inside the neurons of the brain. This figure reflects the continuum of cognitive dysfunction risk, specifically Alzheimer's disease risk, from preclinical to clinical. And so preclinical, basically self-reported experiences or reports of individuals uh, basically reporting on their worsening or more frequent memory loss or confusion that might be a symptom of early stage of dementia or future serious cognitive decline, such as AD. This is also known as subjective cognitive decline. So basically, those who are or individuals who report SCD, they're more at risk for mild cognitive impairment or AD risk, but not guaranteed that they will get mild cognitive impairment or AD risk. While the process with both mild cognitive impairment and AD stages are measured through more clinical objective performance and neurological assessments. There are currently more than 6 million Americans age 65 plus living with Alzheimer's disease, a number that is expected to be more than double by 2050. While older, Black African Americans are 2 times as likely as non-Hispanic whites to have a AD or other dementia-related disease. Research has not identified common causes for this disparity. while Black African Americans are about two times more likely than whites to have Alzheimer's disease and other dementias. They are only 34% more likely to have a diagnosis. Now, this study with my collaborators, I was one of oh, I was working with one of my with my collaborators, Dr. Darlingtina SK and Roland and Dr. Roland Thorpe and Candy and the others. We conducted a cross-sectional study with 117 Black men with an average age of 40 years old. And we examine neighborhood problems, vandalism, litter, noise, pollution, bodily symptoms, aches, pain, breathing difficulties, tiredness, length of residency, and sleep difficulties. And we found that it was correlated with subjective cognitive decline in Black men. Now, there are some interesting key historical time points that contribute uh, to medical mistrust and amongst Black men. And so there's some key historical points. I mean, I won't get too deep into it, but basically the whole idea behind, highlighting some of these key points is also highlighting the fact that there was a recent another study by Dr. Lisa Barnes who identified and who examined those individuals, specifically Black African Americans, who had experienced segregation um, and had to do cognitive performance tests. And what she found was that those who experience some aspects of segregation tend to do poorly on cognitive tests. So the reason why I highlighted some of these different key historical moments so we could understand and connect with not just segregation, but also the different key historical moments that have contributed to discrimination and other systematic and structural inequalities that contribute to some of the challenges and psychosocial risk factors that Black men have experienced and also contribute to the medical mistrust of Black men. In speaking in segregation, part of the historical patterns has led to unethical challenges that developed issues of mistrust in Black communities, in particular among Black men. And then the lack of trust in the healthcare system, it provides its providers and medical treatments. Addressing mistrust allows for equitable health care outcomes and culturally competent research. Historical events, racism and discrimination, and other everyday experiences influence medical mistrust. And this leads to decreased healthcare utilization, as mentioned in previous presentation, utilization, late stage diagnosis of the disease, and hesitancy in clinical research participation. Black men experience higher rates of death, disparities, and poor health outcomes due to this mistrust. Health disparities with Black males. Black males have the lowest life expectancy in the US at average 72 years old, which is about 4 years shorter than the life expectancy of white men and women. 4 in 10 Black males age around that age or older have high blood pressure and rate 30% higher than white males. Black men are less likely to receive guideline consistent care and be included in research. Black men are more likely to receive misdiagnosis when expressing symptoms related to mood disorders or PTSD. And Black males have twice the risk of stroke compared to other groups. Sleep disturbances is more prevalent in Black males, as mentioned before, and specifically to obstructive sleep apnea, or OSA. And African Americans tend to be diagnosed at a later stage of Alzheimer's disease, limiting the effectiveness of treatments that depend upon early intervention. Psychosocial risk factors that impact Black male caregivers. According to the American Association of Retired Persons, the report Caregiving in the United States estimated that 2.5 million Black men are family caregivers and more likely to have lower incomes and be unmarried. This is one, so this study is based off one of my publications of my dissertation. And basically, what I found is that Black males are at greater risk of systemic racism in the job market, driven by depression, anxiety, and stress, and limited choices in employment opportunities. Um, and so we can go deeper later if anybody has questions. Want to also, and so when we think about some of the challenges and systemic inequalities, one can consider also weathering hypothesis, as some scholars have indicated that these racial disparities, specifically Black males, experience early health deterioration as measured across biological indicators of repeated exposure and adaptation to stressors, racism, and discrimination, contributing to weathering and contributing to the accelerated physical, mental, and cognitive dysfunction. For example, traumatic events related to racism have been unrelenting for Blacks. And in good times, racism is a stressor, and in bad times, racism and is a trauma. I've mentioned previously, one should consider the life course perspective, the theoretical framework, and the four tenets, historical time and place, which I've mentioned in some capacity, the timing of lives, the link to lives, social connections, the role of human agency. Um, a life course perspective comprises of patterns influenced by intergenerational cumulative inequality or the transmission of the inequality across multiple generations over the lifespan. So there are obviously, mentioned earlier, potential modifiable risk factors that can increase the risk of AD and sleep issues, cardiovascular disease, diabetes, hypertension, high blood pressure, bad nutrition, loneliness, depressive symptoms, Parkinson, change in BMI, olfactory, which is really the sense of smell, insufficient sleep, and being a current smoker. And so there's obviously ways to decrease risk, which is occupation, cognitive activity, physical activity, a mix of both resistance and aerobic, social activity, social networks, omegas, Mediterranean diet, living a purpose and meaningful life, and sufficient sleep. However, most studies, as mentioned before, most of the investigations and studies are conducted in predominantly white samples or mixed samples. And hence, I totally agree with the previous sentiments that we should be looking within groups and looking at specific, um, uh, the specific issues amongst Black men. So sleep and Alzheimer's disease, it's a two-way street. Some use the term bidirectional. So on one end, deterioration of the brain regions, neural connections results in poor sleep. Um, and poor sleep can contribute to cognitive dysfunction. So poor sleep, OSA, sleepiness, can contribute to some aspects of cognitive dysfunction. We can get into that later if you want. Healthy lifestyle behaviors and healthy brain aging in men. So there's multiple healthy lifestyle behaviors that may reduce risk of physiological and neuropsychological measures to an estimated 50 to 70%. And healthy lifestyle behaviors is linked with physical and mental health, and it lowers your risk of, as mentioned before, diabetes, heart disease, obesity, depression, attention, loss of productivity, better cognition, and mortality. Social determinants of health are the conditions and environments where people reside, born, worship, work, and age, and the impact of their health, well-being, and quality of life. There are five major SEOH domains, economic stability, education access, healthcare access, quality, uh, and neighborhood and built environment and social community context. So health equitable approaches for Black males and brain health. So I obviously I provided a list of ways to kind of to incorporate a certain strategies. So implementation of cognitive health, literacy, sleep memory programs for all groups and all ages of men, from early screening and treatment for cognition disorders starting in preschool, elementary schools, high schools, university, awareness, cognitive health access for ethnic and racial minorities, but specifically to Black males, could be achieved through the creation in multilingual cognition centers in vulnerable communities. Culturally tailored behavioral cognitive health interventions may increase adherence to physicians' recommendations among racial and ethnic minorities, specifically in Black men, and training programs across all educational levels, which aims to increase diversity in brain health medicine. Public health policies to address and reduce the burden of environmental noise, light exposures that are underpinning the contribution of brain health among racial ethnic groups, particularly among Black males, I would strongly encourage. So as I conclude this presentation, I think there's some key takeaways that we can kind of highlight. There are many causes of dementia, and everyone is at risk. However, health disparities and psychosocial risk factors, social determinants of health, increases this risk amongst Black African Americans, especially amongst Black men. The life expectancy, men have the lowest expectancy at 72 years old. Um, and Black men experience higher rates of mortality disparities and poor health outcomes due to this medical mistrust. And it's something that I think we should kind of address because it's ongoing. And so we have to be and create culturally sensitive and relevant strategies for this. Decreased dementia risk comprises of multiple solutions and multi-modalities and multiple methodologies and mixed in addressing cognitive social activity, physical activity, good nutrition, living a meaningful and purposeful life. And future efforts should focus on community outreach and culturally tailored approaches that address barriers to cognitive health amongst Black men. And thank you again for listening.
Dr. Briggs, thank you for an outstanding presentation. Now, our next speaker is Mr. Christopher Barnes. Mr. Barnes is a seasoned professional with over 2 decades of experience in executive leadership within the nonprofit sector. Chris currently operates as the president of Barnes and Associates Consulting, LLC. He has experience managing multi-agency organizations and overseeing the fiscal operations for nonprofits, including Head Start program. More importantly, though, Chris is a proud father of three, two daughters and one son, a role that fuels his dedication to supporting organizations and fortifying education systems. Chris's focus on education was inspired by his mom, who was the first Black graduate from Towson University in Baltimore. He is a graduate of Johnson & Johnson Head Start Management Training Program at the Anderson Business School at UCLA and the Nike Leadership Fellows Program. He holds a Master's of Public Administration from the University of Baltimore and a Bachelor of Science in Business Administration from Lincoln University. We're excited to have Mr. Barnes share his caregiving journey with us. Without further ado, Mr. Barnes.
Thank you, Dr. Thorpe. I really appreciate that. I want to see if your services can be rented out. We can get you. I can get you to follow me around and give me that wonderful warm introduction every time I do something like this. But I really appreciate that. And in addition to that, I want to also shout out Dr. Briggs. That was great information. I appreciate you sharing. Also, want to, in the spirit of just kind of gratitude, I want to offer Dr. Pettigrew and Emma a huge shout out and thank you for number one coordinating this event and also being able to display my slides. It has been a day, and I appreciate the fact that they were able to support me in this way. So again, welcome everyone. Thank you guys for joining. Again, great information. I think this is a really important topic, and to me, it's a really it's personal because as I mentioned in my bio, my mom was a huge impact. Both my mom and dad were huge influences in my life, and having to be a caretaker in this experience and also with my dad has been very sobering and it's been humbling because in a lot of times we find ourselves, and I don't mind dating myself. Look, Dr. Briggs, listen. Sometimes we try to get away from it, but I am in the Gen X community, and I've been around a couple days.
I'm with you. A bit
Yeah,
about you.
exactly. So we're Gen Xers, and but in addition to that, we're part of that sandwich generation as well. So, and when I say sandwich generation, I'm talking about we are in the generally speaking in the middle of either raising young children or children, young adults who are growing into and coming into their adult lives, or and we are assisting or supporting our parents in some way. And it may look different across the board. Some folks may be supporting their parents in some sort of out of home placement or some in a facility, or even in some maybe in a seniors community, or they could have them in the case of myself. I've actually had to move. I had the opportunity to move my mom in about 4 years ago, and I've been the primary caretaker for her. And with all the responsibility that comes along with. So I do want to offer that as the backdrop for the conversation that I'm going to have. So in conjunction and kind of dovetailing on the information that Dr. Thorpe and Dr. Briggs shared, I want to just kind of transition and make this a little bit more personal because I think they gave a really good foundation for kind of giving me some of the qualitative and quantitative information that would kind of really kind of give us the basis for kind of thinking and having these conversations. But what does it look like on the ground? And hopefully I'll share some of my experience and hopefully it'll resonate with some of you all. But I really want to kind of get into what it actually means to be a caretaker and what that looks and feels like firsthand. So, with all of, let me just say it this way. There is I want to start literally from the beginning, but it is sometimes in a lot of ways very hard to kind of share with you, how it looks from when your parents are your everything. They are really the foundation, the core of your being, the fiber of everything that you have become. Like looking at them from that vantage point. And when I say like, that African proverb about a village, that village was absolutely my story. I grew up in a row house in East Baltimore with multi generations. My grandmother was there. I had uncles in the house. I had my mom in the house. So there were a lot of generations. There were a lot of folks that I actually had direct access to. And those folks were literally in those situations my everything. Like when you think about the people that you rely on when it comes to food, when it comes to clothing, when it comes to support, whether it's physical, emotional, I came in the up in the time when corporal punishment was generally accepted. And so, that rod of correction was part of how we consider growing up. And so, with that said, we look at our parents sometimes as the strong pillars of your life that are always going to be there. But as we know, those things change over time. So as we kind of move through this, I just want to kind of give you guys that as like kind of the conversation is going to set the stage for what I'm talking about. My mom was born in 1937. Look, back then, Dr. Briggs, Dr. Thorpe, my understanding is gas was around 10 cents a gallon. I think you could buy a loaf of bread for 9 cents. So that was back in the day. And so, things have changed a lot. She and my mom and dad's family navigated as a part of that great migration north, following the trains. So they actually moved to a small community. Both my mom and dad, that's how they met each other. They actually found each other in a small community outside of Baltimore called Turner Station, Maryland. And if you guys are familiar with Turner Station and Johns Hopkins particularly there, you guys made a comment earlier about distrust or mistrust with the healthcare system. Henrietta Lacks was one of those pioneers of certain things. I know you guys are familiar with it, so don't have to kind of retell that story. But Henrietta Lacks was literally a member of that neighborhood, a member of that small African American community in Turner Station. So that small community has produced a number of folks. And as mentioned in my bio, my mom was the first Black graduate from Towson University. That experience in Turner Station, she went to a high school in Turner Station called Solace Point High School. A guidance counselor kind of remarked her. They kind of noticed some of the talents that she had, some of the skills she possessed. And my mother, being the first person in her family to actually go to college, was inspired by this guidance counselor to go to Towson University. So she started back in 1955 as one of two Black women who decided they were going to, catch as many buses as they need to catch, fight any kind of structural or societal kind of ills or just the climate of the day to make it to Towson University. They did that. And so they, weathered whatever storms they needed to weather in order for them to graduate successfully in 1959. After that, my mom dedicated the majority of her life to education. But for about 50 years, she worked in the Baltimore City school system in a number of different capacities, primarily in elementary and high school ed, and also she worked in special education. But she was dedicated to the community in that way by sharing her skills, her talents with, hopefully influencing a lot of folks. A lot of, we I remember years ago, kind of as a young man walking through like either a mall or Lexington Market or something like that in downtown Baltimore, and like these young men who I thought were way older than me saying, "Hey, I remember your mom taught me. I remember your mom taught me." So just kind of seeing the impact and influence that she's had on a number of folks, that was also inspiring to me. So I say all that to say that, as we move forward, you can go to the next slide. As we move forward, thinking about those younger days when I'm a young man, I'm trying to go through this. This is another picture of my mom and my dad and one of her friends. Listen, I don't know what I was downtown for that day or whatever, but I was dressed to the nine. The point being is that this was part of my village. So as we grew up and kind of matriculated through in and out Baltimore, my mom was working this and another job. She actually taught in the Baltimore City school system, but she also was a adjunct professor at what they call CCB back then, but now I think it's BCCC. So she worked a number of jobs to kind of make sure that I had everything that I needed in order to be successful, to get up in the morning, go to school. She also actually had time after two jobs to come home and check my homework. So how people do it, how, and I'm hats off to Black women everywhere, but how we do it, how you guys make these things happen, and how you're able to kind of put meals on the table, check homework, and do all that. It was all inspiring for me. So next slide. That kind of goes to her experiences in also being that first Black graduate, because she was inspiring and influencing folks in that regard as well. So with her experience being the first Black graduate back in 1959, Towson has dedicated a building in her honor. She also has a scholarship fund in her name that, several students take advantage of every year. So again, I'm just kind of setting the stage to show like there was this woman that really gave her all to people and to me and my family. I have a younger brother who's also a benefactor growing up in that household. And so we kind of knew and we were always challenged by doing better. But then things don't always stay the same. And so back in 2014, I lost my dad. He was a stroke victim as well. And so some of the comments that Dr. Thorpe, Dr. Briggs talked about in terms of Black men and some of the health challenges and health risks that we face on a day-to-day basis, that is all a part of the story. So around 2017, lost my dad in 2014. In 2017, my mom had her first stroke. And so life started to transition. We started looking at things a little bit differently. And so in those spaces, we then have to transition from child, in some cases, to parent. And so that's primarily what happened. There were a number of things in terms of taking on the responsibility of, how do we handle assets? How do we plan for transition? How do we plan for power of attorney, those directives and legal kind of designations that we need to think about and look at? All those things were literally thrust onto my plate. And so I and my village together, because there's a village around me, trust me, I cannot do this by myself. I and my village literally had to think and strategize and plan for how do we now take care of these folks who have taken care of us. So with that said, roughly around 2017, we started making decisions around my mom, try to figure out what that would look like. I didn't necessarily understand dementia. I knew what a stroke was. I didn't necessarily know what that meant and what the recovery would look like. but all those things are on the job training. So again, like opportunities like this for me to take advantage of, listening to the presentations by Dr. Thorpe and Dr. Briggs are really, really important to me. And I think it's important for us to kind of put the messages out there so that in the unfortunate situation that these things do happen or they do occur with your family or within your village, you're more savvy, you're more knowledgeable about how to handle it, how to navigate it, because there are a lot of things. There are folks probably on the call today that I've leaned on their shoulder or asked advice of because this it is a layered and nuanced conversation as we think about how we go about handling business, how do we handle assets, how do we handle the care, the physical care, how do we deal with doctors, how do we deal with the recovery process, because there could be rehabs. How do you determine which rehab is a good rehabilitation center? You don't know. Those things are trial by error. And so, when we think about those areas, those things that we need to focus on, it is important for us to expand our knowledge. At this point, we do know this, that our community, the United States in general, is aging. The average age has grown, and the life expectancy, even though black men don't live as long. I think 72 years old is Dr. Briz, what you mentioned. We're still living longer than we used to some years ago. So because we are living longer, we need to figure out how we are going to take care of our elderly. And so this is all part of that conversation. How do we navigate that process? Next slide. So as we think about it, my mom she actually had a series of strokes, and this is one of the pictures from one of the most recent stays. And she had lost a significant amount of weight. There were some challenges that she had in terms of, dementia was setting in. There was also a Parkinson's diagnosis that I challenged because it didn't resonate well with me. I didn't necessarily see some of the things that they were describing. I didn't necessarily see it wasn't my experience. And so advocacy is a big piece of caretaking, trying to make sure that you are advocating for your loved one as much as possible. Not necessarily going with the first diagnosis, but maybe following up, maybe a second diagnosis, a third, sometimes in the event that you need to, but you're always advocating for your loved one. And that is a big piece of what we do and how we need to kind of think about it. So as we think about their care, it is also going to be even though I don't even play a doctor on television, but sometimes you have to step in that role to say, hey, doc, let's hold on for a second. Let's think about this. What I've seen is this. There have been several circumstances and situations where the doctor may have thought or may diagnosed one thing, and I had to push the envelope. Even something, and I don't want to say simple because it's not simple at all, but even something as frequent or as familiar with folks as a urinary tract infection. Those things, your loved one. And so if the behavior, if the condition, if their health, if their overall sanity is not where you think it should be, I encourage everyone to challenge the doctor, challenge the healthcare system, because there could be some mistrust, but there also could be just flat out a misdiagnosis. And you want to make sure that we're on top of that and kind of advocating for your loved one as much as possible. So those are some of the big things I just wanted to cover. The other piece of it too is that while we're going through and living through these experiences, that life doesn't stop. Life does not stop for anyone. So you're still going to have your careers, whatever you do professionally, whatever you do in terms of recreationally. If you are vacationing, you have to think about who's going to be in place, who's going to be that point of contact while you're gone. If you are literally, if you travel for work, if you have to be out of the house for a certain amount of time, if you're everything has to be coordinated. And that is a huge, huge responsibility. So as we think about your responsibility, I'm kind of bringing it up because there has to be time carved out because you're going to have to come up with a schedule for everything. You have to carve out time for you. How do you take care of yourself? How do you exercise? How do you eat right? How do you meditate? How do you take care of your spiritual, emotional, and physical well-being? That is huge. Kind of going through this experience when you're so focused on your loved one sometimes that your needs kind of take a back seat, and literally it takes a back seat, but nobody else sees that. So you really want to make sure that you are prioritizing yourself because there are so many things going on. I'm not saying that anybody does it maliciously, but because there are so many things going on, you want to make sure that you're prioritizing yourself. So next slide. One of the things that I was absolutely extremely excited to do is that when they dedicated the building, Barnes Hall, if you see it on the right-hand side, when they dedicated the building in my mom's name, that we actually had the opportunity to attend that ribbon cutting ceremony and that we were there. One of the things that we were pretty vigilant about is making sure that my mom, while she can, while she could, she's a little bit more limited now, but that we had her experience as much as we could. So she was there in a wheelchair, but she was still a trooper. She still made it. She was able to participate in the ribbon cutting ceremony. She met a lot of folks. She was able to talk to a lot of folks, and I think she's probably most proud of talking to students who have either benefited from the scholarship fund or were inspired by her story. So those were huge things that I think that we all, that I think we all kind of, kind of reveled in. The other piece of it too is that it is a sacrifice, and knowing and understanding it is a sacrifice. You're going to, I don't want to say that it's not burdensome, because we know we do it out of love. I know that my mom, listen, as many sacrifices that I know and recognize that my mom and dad made for me. I say kind of jokingly, look, if I need to I don't want to be too graphic, but whatever I need to do in order to make sure that they can maintain their dignity and that they are comfortable, I'm going to do. So those things have been important in my life. Those things have been extremely, have kind of literally have started this whole conversation around what does caretaking look like. So as many opportunities as I do, I get to really share with people that it is a labor of love. There's no, to me, no pure expression of love than this caretaking experience. So as we move through this, we know it's a sacrifice, but you have to find time to decompress. Like that love, that emotion, that action word absolutely has to be all encompassing. It has to be comprehensive. So as we think about loving our loved ones, loving on our village, you have to love yourself as well. So that is a huge part, making sure that we take care of ourselves. Next slide. And then the last thing I just want to kind of follow up on, aside from that wonderful experience she had, this is actually my mom, and one of the more recent experiences where the former president of Towson University and one of the leads in I think they call it the Black Alliance, their Black Alliance group, on campus, they were able to kind of take a picture of her and kind of showcase and highlight her and her experiences and her accomplishments. So that was a really big deal for her. Next slide. Another slide is that I'm really proud of is that we were able to take my mom on a couple trips. So even after her strokes, um, we've gone to, I get kind of choked up on this, but we've gone to Turks and Caicos, and we've gone to, and I don't know why I'm like tearing up on this, but this is a cool picture to me. So we went to Aruba and we went to Turks and Caicos. So we got the opportunity to kind of share with her and just throw that stuff out. So it was just a really cool experience. So I just want to kind of end there and just share with you guys that it is caretaking is from the heart. It is a pure expression of what we do. And so, you know, that's my lady. I love her to death. So I'll turn it back over to you, Dr. Thorpe.
Yeah, thank you, Mr. Barnes. First of all, I want to say thank you to both of you, Anthony and Chris, for powerful presentations. Before we transition to our panel discussion, I just want to say one thing. As a Chris, you have a beautiful mother, and you have a big heart, and you are to be commended for that. I've had some experience with it, but it's with the aunt, and it's a labor of love, and it's okay. I just want you to understand, as long as I'm master of ceremony, it's okay to be vulnerable in this space because this is a space that we come to lean on one another, to be with one another. Your mother means a lot to, and indirectly to a lot of us on this call, and I want to say thank you for that. Now I want to move into our panel discussion. Now this is an opportunity for us to ask questions for the audience, to ask questions of the speakers. I'll just kick it off. I want to remind you that I think Dr. Pettigrew asked to put questions in the chat box. And so if you could do that, please do that. But I want to open up with a first question while people may be thinking about uh, questions for the panelists. The first question I have to both Chris and Anthony, and I think, and Chris, please call me Roland. I think this space creates an opportunity for us to let these titles and things go and to be who we are, which are just people in America trying to find a cure and a space for this horrific disease, Alzheimer's disease and related dementias. The first question I have is, from both of your presentation, how should men approach conversations about memory concerns with partners, family, or physicians, so those concerns are taken seriously and addressed early? This question, it sparked this question is because of something you said, Chris, earlier when you said you had to second guess the part about the doctor. So I just wanted to know if you or Anthony had any comments to that question.
And Anthony, let me know if you want to when you want to chime in. But I do want to say this that so so you bring up two extra interesting points. The one thing is, how do you notice that in a loved one? And and then the second piece, the second note to that is it's somewhat subtle when it's happening to you personally.
Yeah.
You literally in some situations, and I kind of say this jokingly, but you oftentimes kind of have those experiences when you come down the steps and you're looking for your keys and you're like, oh crap, they're in my hand. You try to figure out like, is this something I should worry about, or did I just make a mistake because I'm moving too fast? So it's a little bit more subtle. You try to navigate that as best you can when it's personal, and hopefully you rely on your village to share those experiences. But when it comes to a loved one, you sometimes are more in tune with what's going on, and oftentimes when you get to maybe the doctor's appointment, or maybe it could be either inpatient or emergency room visit, those visits or experiences, there are a lot of opinions coming your way in rapid fire. And so you have to help, hopefully, try to navigate all those opinions and that experience because there are a lot of emotions that are kind of running rampant at that point. Trying to navigate those experiences to try to figure out what makes sense and what can you agree with at that point. So my advice to folks just kind of experiencing that is to really trust your instincts. Understand what you know that like I'm sure doctors are well trained, they have good intentions and so forth, but you have the most experience with your loved one. So you're going to know and be able to understand and be able to articulate what you think's going on at the time. And so your voice matters. So I just wanted to share that and then throw it to Dr. Briggs.
Yeah, so I agree to all those points. I'm also would think that so in terms of memory loss, I think when we think about memory loss, it's usually the last it's like the most key component for like MCI or AD risk. It's like the last to go. There's usually other proxies or points before or things that may change prior to. So for example, it could be mobility, walkability, or the way somebody, moves or walks or whatever the case may be. Um, it could be not so much memory, but the issue really becomes the prompt. Like sometimes you may forget something, but usually there's a prompt that that provides you an opportunity to remember what So for example, if you did lose your keys or you forgot the phone number of somebody, there's usually a prompt. Oh, maybe I need to think about maybe it's in that black book I wrote, or maybe it's in a note that I wrote, or maybe it's in, an email I sent or something. There's a prompt. So the issue really is it's like if you can't use the prompt to remember the things, then and it happens over time, then it becomes a challenge. But I think whether you're young or old, we all have a tendency to forget certain things, and it just happens. It depends on if you're stressed. It depends on if you're, going through a hard time, traumatic experience, so to speak. Or it doesn't even have to be traumatic. It could just be a very challenging time where you have too many things on the plate, too many responsibilities, too many tasks, and of course you're going to forget because you're just overwhelmed. And I think those are some of the challenges, the day-to-day challenges. And so, yeah, you may have a tendency to forget, but I think when it happens over time, then I think that becomes more of a challenge. And I think I would say as a black man, if you're experiencing those types of things, then I think what's important is that you have one or two individuals that you could have some sense of accountability, and also that can provide, as you mentioned earlier, that can advocate on your behalf if you are experiencing some of these phases. or changes or transition, so that they can check in and see if, if everything is okay, whether that could be, a partner, or a friend, or family member, or whatever the case may be. So those are just some suggestions.
Thank you. Thank you. Um, we have any questions from the audience?
Good afternoon, everyone. We did have an earlier question um, that somebody asked. They said, is there any way to reverse preclinical or pre-diagnosed dementia?
Well, what was it? Is there any way to reverse? I missed the other part.
Preclinical or pre-diagnosed dementia?
Mm, did you-
I would say I don't know that you could um reverse. I'm not sure, but I think you if you engage in the things that Anthony talked about in his presentation, I think you could impede the progression of it, certainly slow the progression of it. Um, uh, that would be my take of it. Would Anthony?
Yeah, so I think there's like two pre-dementia and preclinical diagnosis. So preclinical is it's if I'm saying it correctly, it would be more subjective cognitive report or self-report diagnosis. So basically, you go into a clinical setting, you do the surveys, and they say, well, you know what, based on the surveys or based off the assessments, you have SCD or subjective cognitive decline. And so that doesn't necessarily mean you have dementia or you have MCI or you have AD. It just means that that particular time in your life, you are have SCD. So it's really the early stages, and there's a lot of other factors that could contribute to that. So, for example, it could be um, maybe you're working multiple jobs and you did this assessment and now you're not in, you're doing this assessment, you're doing it rather quickly. It could be maybe you're, like I said, stressed, depressed, whatever the case may be, all these other factors. And of course, they take these things into account as well. But again, it still doesn't mean that it's a definite that you have MCI. Now, in terms of like protective factors or lifestyle changes that you could probably make, would be essentially maybe better sleep. Perhaps sleep could be an issue. So you may be sleeping 4 hours instead of 7 hours. And so when you do this assessment, most likely you probably won't do well on this assessment. The chances are higher, is what I'm saying. Or maybe it's physical activity. Maybe it's environmental, psychosocial. There's a whole bunch of other factors. And so, some of these things can be changed and modified. And so, yes, you could prevent some of this stuff from progressing further. Now, if it's dementia, dementia is the end. Not I don't know if it's the end stage, but it's really hard to reverse. So you can't necessarily reverse it, but as Dr. Roland Thorpe has said, you could slow down the progression. And by implementing some of these things that I mentioned, physical activity, sleep, social interactions, whether it's with your family, friends, or whatever, you can definitely slow down some of that progression from becoming more severe.
Thank you, Dr. Briggs. We have another question in the chat, and it's a little bit lengthy, so I'll go ahead and read it. Subjective cognitive decline as an early indicator that we should address with intervention, as well as neuropsychological batteries to delineate the role of depressive symptoms in memory loss linked to dementia. African American adults usually express different symptoms that could be indicative of MCI or depressive symptoms. What early interventions should we be emphasizing, and how do we reverse future cognitive decline in this area?
So I can take the first stab at it. I think cognitive training is one of the areas I think that could be that holds promise in this space here. Um, as well as I think it is important to be able to disentangle depressive symptoms from from what could be MCI or what could be subjective cognitive decline. I think that's very important for us to be able to disentangle those things. But I do think cognitive training is a promising uh, intervention that could that may hold some potential benefits in the future.
Thank you. And we have another question in the chat, but before we go to that one, I would like to pose a question to Mr. Barnes, if possible. I'm wondering, in the role of a caregiver, what recommendations do you have, aside for sort of advocating in the medical setting, for really making sure that the person you're caregiving for still has autonomy as much as possible in their decision making, in their daily life, and, the things that bring them joy? Like, how do you kind of ride that line?
Yeah, so that's a great question, Emma. So let me just say it. So there are a few things when you decide to take on a caretaker role. It is again, it's a layered conversation. So you want to absolutely make sure that they have the autonomy and the dignity that it is very hard to give up the car keys and the steering wheel. And I say that literally and metaphorically. It's very hard to give those up. So you want to make sure that you are, again, trying to establish that balance and try to find a way for them to maintain their dignity while you are still in the role of caretaking. The other piece of it is that, sorry about that. The other piece of it is that there are going to be issues like advanced directives and power of attorney. There are some legal designations or legal considerations that have to be a part of the conversation in the event that your loved one is not able or not willing to take care of some of the business related types of functions that they normally take care of. So you have to make sure that those things are in place and those things are discussed, hopefully prior to getting to a life-changing event. And then the other pieces, like you just mentioned, how do we make it fun? How do we continue to have them still enjoy life and as much as possible? So, depending on the ailment, depending on the situation, depending on what that looks like, and I'm not sure, what communities, ethnicities, and so forth, but I can just say that it was not an option for me and my mom to have an out-of-home placement. So we thought about what that would look like, talked about from our village who needed to step up and what roles we would have. And so that was literally, I think, in my opinion, one of the things that keeps her going, to have that constant contact with friends, family, and so forth. So I think that's a really big piece of it.
Thank you.
Yeah. And I have a one question too, and this is maybe for either Roland or Anthony. In both your presentations, you guys referenced stroke, and both my parents were affected or impacted by stroke. So, are there any? You mentioned that we're two times the African American community, two times more likely, I think, Black men, in terms of having a stroke or experiencing a stroke at some point in their life. Are there any factors outside of just, I guess, genetic factors that impact that conversation, impact those statistics?
Yeah, so it's interesting you say that, Chris. So my dad died of a stroke
Wow.
because one of the major factors of stroke is high blood pressure.
Yeah.
He could control high blood pressure. He never filled a prescription at all. He used to he's been an engineer at Norfolk Southern. We're
Mhm.
from the country, so it was we're not city slickers like you all are, Chris.
Right. Okay.
He died of a stroke. Because he had a federal job and he went and got his physical every year because the job required him as
Yeah.
what people, right? But then once he retired, he went to the doctor. He said he had a pulled hamstring. He had a pulled hamstring. They found out his blood pressure. And once he passed away, we found all the prescriptions. He never filled any of them.
Yeah.
Right, things there is uncontrolled hypertension, then the obesity, the common risk factors that you would think of when you think about stroke, and there's the bad cholesterol, high triglycerides, diabetes, those things. A lot of them that in Anthony's presentation, what he talked about was about being mitigating those things through lifestyle modifications. One thing that we didn't talk about that we should talk about is particularly as salient to African Americans, particularly African American men, is diet. The
Yeah.
fellas, we don't want to give up the doggone pork all the time, right? We want fried chicken every Sunday, and as opposed to baked chicken or grilled chicken. You know, I have I've told I'm a Gen Xer, so I'm getting in the age range with you, Chris, where we should be a little more particular and finicky about the
Yes. Yeah.
things we. So when the approach that I've taken, and when I talk to men nowadays about different factors, and particularly diet comes up, I think I talk about the concept of moderation, because if you
Mhm.
talk about elimination, I don't think elimination is sustainable, right? And if you think about moderation, I think it's something that's more achievable and more sustainable. I think it's those factors, and if you can get out and move around, right?
Mhm.
Everybody, I just want you all to know April 1st is National Walk Day. I want everybody on this call to commit to walking at least cumulatively over the day 10,000 steps.
Right.
Cumulative over the day. I see my good friend is on here, Dr. Christine Holman. I'm gonna count you for 10,000. I got 10,000. So that's 20,000 we got committed to right here on the call, right?
Mhm.
So I think and just moving in general, and get out of calling it physical activity or exercise, just moving around, it makes a big difference. So I think those are some key factors there, Chris. And I hope that's helpful.
No, it was. Thank you.
Somebody put in the chat a particular experience that they have during the day. And I'm just wondering if you all can talk about things that may happen from in your day-to-day life that would be cause for concern, like forgetting things or, not, I don't know, remembering things that you normally would, not following your regular schedule, things like that. What are some things from your day-to-day life that may raise concern? I guess when does it rise from the level of normal forgetfulness or, you know, a slip of the brain to something that should be maybe looked at a little bit more closely?
It's tough. That's a tough question, Emma, because I think that it varies. I think it varies. So let me go back to Chris's example, because I had the same example about the independence and the driving. So when my mother passed, I was the one that had to tell her she couldn't drive anymore. My sister, I was the baby boy, and so the bigger sister leaned in on me like that's what you got to do, right? So I had to do it. It is tough, Chris. So I resonate with you. It's very tough, but that varies from person to person, right? It's very difficult, right? So, just you have to think about, the way I approach it is this a one-off or is this a consistent pattern? And if it's a consistent pattern, yeah, now we need to start thinking about this and start approaching it and getting a game plan on how we're going to approach it, particularly something big like giving up someone's independence or something huge like that. And like forgetting your keys. I mean, this morning when I went to the gym, I got all the way to the gym and realized I didn't have my watch on.
Mhm.
I am a watch dog, so then I did the workout without the watch, but because if I come home, I'm gonna go back. But did I get back to the house and freak out? No, because I normally have my watch on, but I did recognize that I need to charge my watch up at the regular time and don't do it at night. That's what the problem was. But it's those things, thinking about when those things happen and are there a pattern, at least from my perspective, are there a pattern? Is that pattern consistent? Then to me, once that pattern you identify, monitoring that pattern to see if it's consistent. I don't know, Chris, you may have had a different experience when it was by the independence with your parents and
No, no, actually, it's pretty much spot on. The interesting thing is, it was so with my dad, it was the exact same thing, literally. So if you guys got time for this 30-second story. So I literally went to his house one day because I understood, I got word from our church community that he was confused at Golden Corral, Anthony. It's kind of a day, this is a while ago. So I actually had this conversation with him. He was, swore me down that was not the case. So what I tried to do was take his keys. So I took his keys. I didn't tell him, but I took his keys and left. I was probably 30 minutes from his house, and then he came riding past me. That means he had another set of keys in the house, so it didn't work. So my point is, it's going to be hard to navigate some of that stuff because these folks, they have their independence and they want to still do what they think they can do. So, in a situation like that, with him, fortunately, unfortunately, he didn't live too much longer beyond that experience. But those are some of the experiences that you're going to have to navigate. Everyone is not going to give up these keys willingly. So just kind of talking through that. Again, you as the caregiver, you as the part of that village or as the loved one, you're going to know and see some of the changes and those things that give you concern, don't take them for granted. And that's where the advocacy comes in. So when they go to the doctors or if you get the chance to go with them to the doctor and they don't seem to be as forthcoming. That happens too. When you get to the doctor, oh no, I'm fine. No, that didn't happen. No, I always have my keys in my pocket. Those things come up, you're able to kind of share and give your experience, and hopefully those things will work out. But I'm not going to say it's going to be easy. It's going to be difficult in some situations, negotiating the the ceasefire.
And I want to just make one comment because I want to make one comment. We haven't said this at all, but Chris has said this, but I want to highlight it. Caregiving is really difficult and is really challenging. And if you don't have a support group or you don't have a support group running, the Alzheimer's Association does have some resources for available for you. I will put the 1-800 number in the chat for anyone that this may or may not be for people, but I just wanted to bring that forward to say that if you don't feel like you have a support group, there are resources available through the Alzheimer's Association. The Alzheimer's Association has a chapter, the Greater Maryland chapter is here in the Greater Baltimore area.
Thank you, Dr. Thorpe. We have another question asking if you could address any factors that might be particularly salient in African American men from a cultural perspective in recognizing and addressing early dementia symptoms.
Yes, I can take the first stab at this one. Two things that are very important: trust, and Anthony talked about this, the mistrust of the medical system, right? A lot of these early symptoms, you will typically get recognized if you're engaging the healthcare system, but oftentimes a lot of men don't engage for the mistrust that happened in the past for one of those incidents that Anthony's had on his slides, right? I think that's one of the biggest things. And getting the other thing is getting African American men to be able to open up and just talk about their medical conditions to one another is another thing. It's one of the most powerful things you can engage. I was I think in Oakland a couple of weeks in early February, and a group of black men were talking about their medical condition, their medical records openly, and it was very shocking to hear that because it's one thing we as black men don't typically do because it is in the past, and I know Anthony can talk about this much more eloquently than me, but it starts to talk about you don't you're weak if you're talking about your weaknesses if you're talking about medical conditions that you may have or you're going to the doctor. Oftentimes I oftentimes say that men in general, but from some work that I've done in the past, black men typically, black men typically, not all, but we believe in health repair and not health maintenance. In the sense that first time we show up many places is through the emergency room, or a classic example is prostate cancer. We didn't go get the preventive stuff, so when we're finally diagnosed, Chris and Anthony, we're stage 3 or 4, and our treatment options are far more limited,
Mhm.
right? And then the prognosis and things are get more defensive. So I think those are some of the things: trust, and then willingness, trust in the healthcare system, and willingness to be able to go engage in the healthcare system and having and finding a physician that will engage in shared decision making and listen to you. I
Mhm.
think those are some important things.
Yeah.
One of the resource I wanted to share as well, and Roland, this maybe can dovetail off the comments that you made. There were comments in the chat. Looks like the chat. Now, there's great conversation in the chat as well, but there were comments related to if you're a caretaker and you don't necessarily have a village or you don't have some of the resources or the family members to support you in that journey. I know there are some support groups that are out there. As a matter of fact, I believe there may be one or two members of, well, actually one of the coordinators or organizers of two of the groups may be on the call. But there, for instance, the Benti Circle, the Mwamba tribe, there are groups that are there to help you navigate the process. And not in a formal sense. There are support groups where caretakers just get together and some of the events are organized, some of them are just unscripted, and we just come together just to have those kind of transparent conversations about what that actually looks like. But those groups are out there. Also, what their resources, state and local resources as well. Like the Maryland has a Department of Aging. I encourage you to go to that website and maybe kind of seek resources there. There could be some public and sometimes private money to support you in your journey around caretaking. This is the other piece, and we haven't talked about it as much, but caretaking can be expensive, meaning the prescriptions, the caretaker support, meaning that if you need someone else, like either professional or semi-private support, those supports can be expensive. So you want to think about and navigate that process as much as possible and try to find out. I found a lot of caretakers and a lot of resources by word of mouth. So again, just kind of putting yourself out there, I think is really, really going to be critical.
Mhm.
And thank you, Dr. Pettigrew, for putting that Benty Circle link in the chat.
And I think to tie in with some of the points that were made before, I think there's some aspects of I think there's you know societal expectations of performative masculinity, of wanting to be strong and wanting to either provide or to be, quote unquote, not breadwinner, but bravado, and so, having a sense of weakness at any moment or vulnerability definitely targets or attacks that sense of masculinity. I think also in terms of the mistrust can be aligned with misinformation. And so they may not have or may think they know or have all the information and want to self-advocate in ways that are not necessarily healthy. And so, for example, if you talk about nutrition, they'll say, "Well, I have it in control. I know what I'm doing." Or self-medication. If I'm dealing with stress or depression, whatever have you, I drink or I smoke or I do whatever the case may be. I'm not feeling pain or I'm not experiencing loss of memory. It's just I had a bad day. And so tend to take responsibility in ways that are not in ways that are not necessarily healthy. And I think those are some of the other challenges underneath that necessarily they're not always talked about. Um, and so that's another, couple of my 2 cents.
Thank you. We only have a few more minutes, but I do want to get to one or two other questions. I think this is directed towards you, Mr. Barnes. Can you comment on how the support and love that you showed your mother may have contributed in other ways to the improvements of her brain health?
Absolutely. So again, and I really want to give a special shout out to my village. So myself, the folks that are around her, I have my children are in the home. So like there are a number of folks that kind of pour into her daily, and she pours into them. So part of it is I think just the connection in general is huge in terms of maintaining and keeping her, I guess, at least slowing the progression of some of these diseases because she has been diagnosed with early stages of dementia. So I think the slowing of the progression, I think, is a huge piece of it. I just kind of give you, recently we have a family member who has made it to the NCAA tournament, and they were put out of the first round, Roland and Anthony. But I'm just telling you, so she plays for Colorado. It's a female cousin. She plays for Colorado. She's a freshman. My mom earlier that week was having difficulty remembering a number of things. And I don't even want to be too graphic, but she remembered stuff that, things that are personal that she should remember. One thing she did not forget was, listen, is the game tonight and can you turn it on? So that connection to me was huge. That was worth the price of admission for me because again, she forgot almost everything that week, but she did not forget that the game came on Friday at 9:30.
Good, good. So I think I want this time I want to turn it over to Emma and Corinne. I want to first say thank you to Chris. Please join me in giving Chris and Anthony a round of applause for the presentations. And also join me in giving a round of applause for Emma and Corinne for putting all this together. It's a Herculean effort. I really appreciate all the work that you all have done and all of the sponsors. So I'll turn it over to you, Emma.
Sure.
Mhm.
It was very much a shared effort, but thank you for the acknowledgement. So for those of you who don't know me, my name is Emma Mitchell. I'm the program manager at Morgan Cares, which is the community engagement core of the Center for Urban Health Disparities Research and Innovation at Morgan. We have a network of a number of community groups, leaders, other folks from Morgan, faculty, students, and partners at other institutions. And we have a network that we kind of operate to support connections between these groups. We offer a number of training opportunities. We have 2 seed funding opportunities. And so if you're interested in learning about any of these things, feel free to scan this QR code, sign up. It's more than just a mailing list. We do have what we call our directory, which allows you to set up a profile to share about the work that you're doing, partnerships that you're interested in engaging in. And if you'd like to talk more, I'm available. You see our Morgan Cares email at the bottom, as well as our webpage. And that is my office number listed there. So feel free to reach out. And I'll pass it over to you, Corinne.
All right, well, thank you everyone for attending today and for our great presentations and excellent conversation. Really appreciate the time that everyone put in and the thought to our audience in responding to our audience questions. My name is Corinne Pettigrew. I'm with the Johns Hopkins Alzheimer's Disease Research Center, and I just want to share an opportunity that is always ongoing because we have a large number of studies at our center that are looking for individuals to participate in aging and memory loss research, whether it's observational studies that involve memory testing, brain imaging studies. There's also intervention studies going on. And because we have such a large variety of studies going on, we're looking for individuals both with memory concerns as well as those without. So if you're interested in learning more, I'm happy to follow up. You can visit our website, which has a participate in research website form, or call the number on the screen, which I believe is my colleague Jessia Gavin's phone number. She's on today's seminar as well. And that's it. And just thank you again for everyone coming today and attending our session. And we hope to see you next time, which will likely be in the fall.